This is a pretty tough question, and there's a lot of movement in this space recently. So I think the main principle to understand with the neoadjuvant approach is that it fundamentally seeks to achieve the same thing as adjuvant therapy, which is elimination of micrometastatic disease, resulting ultimately in preventing recurrence after complete surgical excision of all evident disease. So a lot of the time, people think neoadjuvant treatment is about debulking a tumour to make it more easily resectable. And although I think undoubtedly in some cases that does occur, it really isn't the primary goal, and it wasn't the intention of most trials that were designed to evaluate neoadjuvant regimens. So many patients enrolled in those trials had relatively small volume disease, or at least they didn't have clearly high volume, what we might call borderline resectable disease. And so neoadjuvant data by definition has to be seen as applying solely to patients with clearly upfront resectable disease. So in terms of which patient to consider neoadjuvant therapy for, it's basically anyone you might equally consider suitable for adjuvant therapy. So the second point to consider is what is the mechanistic basis for thinking that neoadjuvant therapy might be superior to adjuvant. Activating an immune response while there is macroscopic disease in place might facilitate easier or better education of a melanoma specific immune response, remembering that the drugs we're currently using in the clinic are non-specific immune stimulators. So the preclinical studies that motivated neoadjuvant therapy were more akin to resectable stage 3 or an artificial localized stage 4A disease than true stage 4 disease in human patients. And insofar as the purpose of systemic therapy is mainly to mop up micrometastatic disease, the resectable stage 4 patient differs in one key respect from the resectable stage 3 patient. The stage 4 patient has already proven that they had micrometastatic disease and is therefore presumed to have other micrometastatic deposits in situ, which could be useful to adequately train the immune response, whereas the stage 3 patient only might have residual micrometastatic disease. So back to the question of which stage 4 patients should get neoadjuvant or adjuvant therapy. There's not much data for neoadjuvant approaches in resectable stage 4. In the SWOG 1801 study of neoadjuvant plus adjuvant versus adjuvant only pembrolizumab, only 7 to 9% of patients had stage 4 disease at study entry. And with a small number of events in a small number of patients, subgroup analyses did not really confirm a clear difference between the two treatment strategies. I take a bit of a pragmatic approach at this point and assume that in time, the data is likely to show that for stage 4 patients, the neoadjuvant and adjuvant approaches are at least similar. So the question really just becomes, what is the data around adjuvant therapy in stage 4 patients? And fortunately, there is some. So in Checkmate 238, which was a study of nivolumab versus ipilimumab in resected stage 3B, 3C, or 4, only about 18% of the patient population was stage 4 at study entry. And of that, most of them were stage 4A, so 11%. There were some resected brain metastasis patients included, 1%, bearing in mind that this was the 7th edition of AJCC staging, and so they were in stage 4C. And mucosal and acral were allowed, but also very small numbers. So the primary endpoint of this trial was recurrence-free survival, and that was met for the total population, and it led to registration of this regimen. Post-hoc analyses for recurrence or death trended to favour nivolumab for stage 4A and 4B, and favoured ipilimumab for stage 4C, but neither was statistically significant. And the results didn't really favour either agent for mucosal or acral histologies. Like other monotherapy adjuvant studies, despite recurrence-free survival benefits, we still don't have a proven overall survival benefit. So these studies don't answer the question of whether stage 4 patients truly benefit in the long term from single-agent immune checkpoint blockade in the adjuvant setting, as opposed to its use at the time of first recurrence. The other key study in this field is ImmunEd, which was run by the German cooperative group. It was a phase 2 resected stage 4 patients randomized to receive ipilimumab plus nivolumab standard regimen dosing versus nivolumab versus placebo for up to 12 months. And 167 patients were randomized. So there were nearly equal amounts of M1A, B, or C, again in 7th edition of staging. And this showed that there was improved recurrence-free survival in the combination group versus placebo with a hazard ratio of 0.6. There was also an improved overall survival for the combination against placebo with a hazard ratio of 0.41, but that wasn't also shown for the nivolumab monotherapy arm. The landmark 4-year overall survivals were about 83.8% for combo, 72.6% for Nivo, and 63.1% placebo. So at least numerically, a gradient of response. The pre-specified subgroup analyses showed superiority of the combination to placebo for stage 4A and 4C, but somewhat strangely not for 4B. And nivolumab was only superior to placebo for 4A in subgroup analyses. So essentially my take on this is that these results appear to be driven largely by stage 4A patients and are most apparent for combination rather than single agent nivolumab. And importantly, it has to be put in the context of toxicity. So the toxicity rates were quite high. Treatment-related grade 3 to 4 adverse events was 71% in combo and 29% in Nivo. I think it'll be interesting to see if biomarkers such as circulating or CSF tumour DNA can be developed that help decide which resected stage 4 patients will truly benefit from adjuvant immunotherapy. At least based on the current data, the patients who look most likely to benefit are those with stage 4A, non-acral, non-mucosal, cutaneous melanomas. And in summary, I think the key considerations when you're presented with a patient in this scenario are, do I think this patient will have good long-term survival anyway? And do they have sufficiently good risk disease that the potential benefit of adjuvant immunotherapy applies to them? The thought being that really if they have very high risk disease, they're not likely to get a lot of benefit, even from combination therapy. Do I have access to the proven active regimen, which in this case, I think the most proven regimen is ipilimumab and nivolumab combination? And if I give something to this patient in the adjuvant setting, is that going to impact what is available to me if the patient subsequently relapses, considering the restrictions that we currently work under in terms of funded and subsidised supply through the PBS? And lastly, as I mentioned, the 71% high-grade treatment-related adverse event rate, is that acceptable for an approximately 20% increase in absolute survival at 4 years, at least based on the IMMUNID study?